Welcome to the Strategies for Reducing Readmissions in the Inpatient Psychiatric Facility Setting conference call. My name is Jenny, and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. I will now turn the call over to Ross Gaske. Mr. Gaske, you may begin.
Thank you. Good morning, everyone. My name is Ross Gaske, and I'd like to welcome you to today's webinar, Strategies for Reducing Readmissions to the Inpatient Psychiatric Facility Setting, presented by the Lake Superior Quality Innovation Network, or LSQIN. The LSQIN is comprised of three organizations: MPRO in Michigan, Stratis Health in Minnesota, and Medify in Wisconsin, to support the Centers for Medicare and Medicaid Services priorities for healthcare quality improvement. We know that you and your organization are working hard to improve healthcare quality, reduce readmissions, support the culture of safety, and improve patient outcomes. We hope that what you learned today will help you be successful in these efforts. This session is being recorded and will be available in about 2 weeks. The PowerPoint presentation is a WebEx handout, and the link to the handout information is also in the chat box. We will remind you how to access the handout and our recording at the end of the session. All lines will be muted during the webinar. However, we will have time for questions and answers after the presentation, so please be fully present and engaged, and make a note of any questions that you may have as you listen. Feel free to also share your thoughts in the chat box. Because Medify is providing continuing education credits for this presentation, we need to inform you that no commercial support has been received for this learning activity. The speaker has reported no conflicts of interest, and there are no planned or conflicts of interest. For CE credit or a certificate of attendance, you must attend the entire session and complete an online evaluation that you will receive during this presentation. We encourage everyone to complete the evaluation to provide feedback on this session. And once again, that online evaluation, the link to the online evaluation is in the chat box. With that, we can now introduce today's speakers. Dr. Kay Jewell is president of Terra Center, a healthcare consulting firm. She's also worked in quality and safety issues at the state and national levels for 32 years with physicians, nursing homes, home health, hospice, and hospitals. She has extensive experience in the area of health policy, quality improvement, and quality measurement. Her current work focuses on education of healthcare providers, pharmaceutical companies, and the public on quality and patient safety performance improvement, analysis of clinical conditions, guidelines, and identification of gaps in measures, and the active participation of consumers, physicians, and others in the public comment process. She served as a medical officer at CMS and the medical director for the Wisconsin Medicare Part B contractor. She has a wide range of experience in mental health as a provider, a family member, caregiver, and community advocate, educator, and facilitator of local support groups with the National Alliance on Mental Illness. Her current work includes community projects with parents of youth with mental health conditions, juveniles detained at the detention center, and peers and consumers. She is the past president and crisis intervention partner for NAMI Portage in Wood Counties in Wisconsin. Dr. Jewell received her medical degree from the University of Wisconsin School of Public Health and Medicine, completed her internal medicine residency at the UW-PHM Milwaukee campus, and fellowship training in psychiatry and geriatrics at the Middleton VA in Madison, Wisconsin. Sue Abderholden has devoted her career to changing laws and attitudes that affect people with disabilities and their families. For the past 12 years, she has served as the executive director for the National Alliance on Mental Illness of Minnesota. Under her leadership, the organization has grown tremendously, from being in the shadow to becoming the state's most effective advocacy organization. Programs have expanded, and NAMI has been the key advocate at the legislature for children and adults with mental illness and their families. Ms. Abderholden has received numerous awards for advocacy. In 2013 alone, she was awarded the Exceptional Individual Achievement Award from the National Council for Behavioral Health, the Gaylord Anderson Leadership Award from the University of Minnesota School of Public Health, Distinguished Service Award from the Minnesota Administrators for Special Education and a Distinguished Community Partner Award from the University of Minnesota School of Social Work. She has held positions with ARC of Minnesota, U.S. Senator Paul D. Wellstone, and the Pacer Center. Sue has a BA in Political Science from the McAllister College and a master's degree in Public Health Administration from the University of Minnesota. With that, I will turn it over to Dr. Kay Jewell to begin today's presentation.
Thank you. And when we first start talking about looking at readmissions and where to go, sometimes I think both as patients and as family and even as providers, we can feel lost and insecure and uncertain of how we should proceed. So hopefully in this webinar today we'll start to address some of those, decrease some of that confusion. Our objectives are to identify some of the elements of a comprehensive strategy for reducing readmissions and organizational assessment, identifying resources and innovative approaches to address our process gaps and reduce our readmission rates, and discuss available community resources that will improve behavioral health outcomes. Looking at the data for our 3 states, nationally the readmissions from the inpatient psychiatric setting are 21.5%. In this region, it's 21.29%. These are the mostly recent data from the fourth quarter of 2015 to 23rd quarter, 2016. Schizophrenia is at the top with 22.85%. Then substance-related disorders, personality disorders, mood disorders at 21 and 7.73%, and then alcohol-related disorders. It's tempting to start with the 5 key areas that have been identified. There's been a great deal of research and collaborative work looking at the issues of readmissions and specifically readmissions in mental health facilities. One of the main resources that has looked at this is actually out of Minnesota, which is the Hospital Association in collaboration with lots of organizations in the community, including NAMI Minnesota, had an initiative and then came up with recommendations, including mental health recommendations. The 5 areas that all of the different organizations and studies have come up with that they share in common would be client family engagement and activation, medication management, comprehensive transition planning, care transition support, and transition communication. It would be tempting to start with these and start looking at what you've got to do, but that's not how we do things in quality improvement. It would also be tempting to start by analyzing your data, because that's what we need is data, identifying high users, high utilizers, or those who have high rates of readmission, and do an analysis, in-depth review with the case conference. This is necessary to do, but it's not necessarily the next step. And the analysis should include interviews with the inpatient team, outpatient providers, care coordinators, if a person goes to residency of the residency, as well as the individual and or their caregivers. But this is still jumping the gun. It's important, as we know, as quality improvement process, to start with the process and engaging all of the relevant services onto a team to look at what are the issues, including our community partners. This is obviously easier when you guys are when there's an integrated system, as opposed to a facility that has significant number of admissions, either at a distance or not part of an integrated system. Then there's the root cause analysis, which would take us back to that in-depth analysis. Looking at our data, including patient characteristics and settings, et cetera, tracking clients and interventions, and outcomes over time. I guess the bottom line is there is no silver bullet, as there often is in most quality improvement. Especially in this area, we're going to need mutually reinforcing interventions across the continuum of care. For today, we are going to focus on those 5 key factors that have been identified as issues for readmission, and we're going to start with patient and family engagement. And you're going to notice an interchange of words. As part of stigma and changing our mindset, it's also about what words we use. So instead of mental illness, it's like mental health conditions, just like it's physical health conditions. And instead of patients, a lot are still starting to refer to individuals as clients. In one facility, in a webinar, they've changed their interviewing room to their participation room because they feel like that's what the purpose of the room is to work together and participate. So, and with that, I will turn it over to Sue to talk about client and family engagement.
Thank you. So we often don't really talk about patient and family engagement and activation when we talk about reducing readmissions, and we think that this is critical. The first thing is to really think about, I think in the mental health field, we don't really engage families very much. So I think it's really important to remember that none of us get through a serious illness by ourselves. Whether it's cancer, whether it's having a new baby, whatever it might be, we depend on others to get through that. And it's not just people who are paid to be with us. One thing that we found often in talking to both people with mental illness and their families is that many people with mental illnesses are discharged from the hospital without anyone in the room. And we know for so many other healthcare conditions, patients are told, have someone in the room when you get discharged because you're not going to remember everything that you've been told. And somehow we don't really do that when it comes to mental illness. If people don't really understand their illness or the treatment plan, or they weren't involved in developing the treatment plan, the chances of them being readmitted are actually very high. We did a survey of people with mental illnesses and their family members. And when we looked at the data from people with mental illnesses, what we found is that only 25% got get-well cards. And I think, as all of you know, people are usually in an inpatient unit more than a day or two, typically 8 to 10 days. 86% got visits from families, which means that many people actually do have involved family members. A lesser percentage in terms of visits from friends, 45%. I think the next couple are really troubling in many ways. So people did not have an easy time staying connected. And I think we all know that, especially with mental illnesses, we want people to stay connected. We don't want them to isolate, and yet many of them were not connected at all. Their family and friends weren't involved in the recovery or treatment plan, and they themselves, only 25%, felt that they were involved in their own treatment plans. We asked them, did you have someone with you at discharge? Only 27%, which I think everyone would agree is not nearly high enough. Only 27% were encouraged to sign a privacy release. This is a really big issue because we think that, I think sometimes it's a misinterpretation of HIPAA, but, we can't talk to the family because we don't have a privacy release, and yet only a small percentage were asked to even sign one. They weren't provided, less than half were provided information about their illness. 43% were provided information about the medications and side effects. Only 41% had input into their treatment plan. Only 45% felt that they would listen to, and only 40% were offered hopeful words about recovery, which we think is really in many ways tragic. What we want to do when someone is inpatient is really to help them in terms of the recovery, to give them hope. I would say that most of us think we're going to get better unless we have hope. There are some quotes from the surveys. I would have liked to have had more information on my new medication when I first started on it instead of getting it from the Target pharmacy after I got out. Another person said, treat me like a patient with an illness, not like I'm incapable of making good decisions. And lastly, due to my mental illness, physical symptoms were disregarded as figments of my imagination. And when we're thinking about providing whole care to someone, clearly we need to listen to them about what their physical symptoms are as well. We also interviewed families to see what they found as well in terms of hospitalization. Only 30% got a signed privacy release. Only 27% were provided with information about their loved one's illness. 26% about information on the medications and side effects. only 11% were taught what to do to help. And I think this is really critical. We don't really learn about mental illness much in the community, and so they're really counting on the professionals in the hospital to help them know what to do next. Only 31% had input into the treatment plan. Only 40% were told or felt like they were showed empathy, and 34% were provided hopeful words. So again, I think people's experiences were generally somewhat negative and not engaging, and that would, of course, make it more difficult for someone to stay out of the hospital. Two quotes from family members. One was, we had to ask if they had a video or something to read to help us when our 18-year-old son was hospitalized while he had been in college. There was no support for us as parents. We had to find that on our own and in our own community. And another one said, they could have included me, consulted with me, and not dismissed me. And we hear this a lot from families, that their perspectives about their loved one are frankly dismissed. Some other quotes were, parents who are obviously the only other contact of patients should be included in the treatment, care, and discharge. There could have been more descriptions of the unit rules, population. It was my son's first time in an adult unit, and staff could have treated me like a caring parent, just like they would for a child with cancer. I think sometimes what families have certainly told us is that, kind of the old saying, the apple doesn't fall far from the tree, that's how they're viewed by the professionals in the hospital. So I think it's really important, if we're really going to reduce the number of readmissions, to really recognize how important family and friends are. I love Michael J. Fox's quote, it's not an important thing, it's everything. So let's look at what families provide. They provide a lot of social support to people, especially people who have a serious mental illness. That might be the only one that they have contact with. Many young people, particularly with schizophrenia, will tell you that their friends disappear, they scatter. Many of them are young, they don't know what to say in their 20s to a friend who's developed schizophrenia, and so often these young people only have their family to support them. We know that social support helps with a number of things, including physical health and just a better quality of life. Sitting in your apartment all day watching daytime TV is not going to help you get better. Families also provide a lot of practical help. We don't have enough support systems, paid support systems in any state to really help with this. Driving, whether it's to get groceries or to get to an appointment, many families provide supplemental income because what people are living on is not enough to pay for their rent or for food. We don't have many job programs that really help people with a mental illness, so family members often step in. I think the other thing that happens too is families help with things like monitoring stress. I like to say that families are really the canaries in the coal mine. They know when things are starting to fall apart. And then families also provide a lot of they provide information to the person, a lot of encouragement and advice to help them on their recovery journey. I'm trying to, there we go. We've already talked about the early warning signs. Families are often the record keepers as well. Any of you who have filled out Medicaid applications, all of those kinds of things, families tend to keep that and help the person stay on top of all of that paperwork that you have to fill out when you are on government programs. They also see, because they knew this person before they became ill, they see their strengths and their talents. And I think that's a really important part of recovery. So they're not just seeing them as a person with a serious mental illness who's been hospitalized. They also see them as, a musician, an artist, someone who brought humor to family events. They see them as a whole person. And then lastly, they're the advocate. Many of you know how hard it is sometimes to fight with insurance companies and, with counties and state governments about benefits. And often it's the families who really have to take that on and provide that advocacy for the individual. Families need a lot, too, when their loved one is hospitalized. A big one is encouragement and hope. It's really difficult sometimes to see your loved one hurting that badly and ending up in the hospital. And if it's the first time someone's been in the psychiatric unit, it's a really difficult thing. And so they really need that kind of, help through that process. they're often worried about what's going to happen, what does their loved one's future look like, and so they really need some support from the hospital staff about, yeah, those are real worries, but recovery is possible. The fifth thing is around respect and empathy. Many families have talked about how they just don't get the empathy as they would for any other illness. We have plenty of examples where we had a NAMI member whose husband had first started out with epilepsy, and she was very involved in the care treatment plan. She could call the neurologist whenever she had questions. There was just no doubt that she was involved in that team. He was then hospitalized for a week, and it was found out that he actually had serious depression, which caused non-epileptic seizures. And at that moment, while the symptoms were clearly the same, but the diagnosis had changed, she was literally voted off that island. She was no longer involved in the care team. No one would talk to her. No one would even listen to her concerns about what was happening with her husband. And that was just a key example about how we treat families differently depending on the diagnosis. And then honest and caring communication. They need to know that, perhaps if it's their young son who's in their 20s and has been diagnosed with schizophrenia, recovery is possible, but it is going to be a difficult road. And they also need to know that, perhaps their view of what the future would be for their son or daughter might be changed as well. Families need to know. They need lots of information, and what are those resources? If you working in a hospital have difficult knowing how to access and navigate the mental health system, think about how much more difficult it is going to be for a family member. So they actually need to be educated about, you should be asking these kinds of questions about medication or about therapy. Here are some good websites to go. Here's NAMI. You can go to them for education and for support groups. They need all of that information so that they, again, can be good advocates for their loved ones. One of the reasons families want information is not to be meddlers. One, it kind of reduces their anxiety about what's going on with their loved one if they have really good information. They want to have appropriate expectations for their loved one. They don't want them to be too low, but they don't want them to be too high as well. How do they motivate their relative? Probably the biggest question we get asked is, what do we do when our loved one doesn't believe that they're sick? How do we help them get that help? They want to find out about mental illnesses. So again, they want to be good consumers of health care. They need that information. And they want to know what to do when there is a crisis. Who do we call? Do we call the professional? Do we call a crisis line? What do we do about that situation? We want to make sure that families really understand the diagnosis, including the symptoms that go along. Symptoms can be difficult because you're not really sure what that's from. Is it someone just being belligerent? Or this is really a symptom of the mental illness? Is this a side effect of the medication? When should I worry? When should I call? There's specific suggestions for coping with the symptoms, whether it's, take that walk every day, really watching your nutrition. Dealing with practical issues around these kinds of things and making sure that they can get their loved one and themselves into peer support groups so that they know that they're not alone. That can be a really difficult part of this journey. It's not like you talk to your coworkers over lunch saying, gee, my son was just diagnosed with bipolar disorder. Do you know a good therapist? Those conversations don't happen, and so families feel particularly isolated about this. If we want to have true family engagement, you really need to involve them in the discharge and treatment planning. They're also going to be able to provide you with information about whether some of this makes sense or not. If you're in a very rural area of a state, having to go somewhere where transportation is an issue, then someone's not going to be able to follow through with that treatment plan. So really involving them. And one thing I just want to mention is that under HIPAA, you can do a verbal agreement. The person doesn't have to sign the privacy release. They can just say, yes, it's okay for my family member to be in the room so that they can hear what's going to happen next. And often people are much more willing to do that than sign a full-blown privacy release, especially if they're still feeling a little paranoid about what happened or if they're mad at their family member for getting hospitalized, bringing them to the ER. So again, you can do this verbally, and that's much easier than to talk about. Many families say that no one ever asked them information about what led up to the hospitalization. And oftentimes, especially for someone who's been ill for a while, families have great history about what medications have been tried before and have not worked, how someone reacted to, particular medication, what other kinds of supports worked and what didn't. And so I think it's really important that they be asked those questions, and that will actually help in terms of recovery as well. And then make sure that families understand what these treatment strategies are. They may have to explain this to their loved one a couple of days later, a week later, and so if they don't have any information, they can't actually share that with their loved one. True family engagement actually provides timely reports on how things are going. Sometimes people are coming into the hospital in the waiting area and they're really not sure about what's going on. They're not sure that their loved one is getting better or not. And as you know, it could be the time of day, it could be all sorts of things that were happening at that moment. But making sure that they understand what's happening is really important. And then making sure that they know where to go if they actually have a complaint and a grievance. I will tell you that often the complaint or grievance for someone who is hospitalized, that a lot of those are sometimes ignored because they feel that maybe the person's illness is getting in the way. But they are very valid complaints, and the family members that are bringing them, they need to know where to go as well. Please listen to their concerns. And we've had many, countless families say that, they're worried about some side effects, they're worried about something that's going on, and, again, they're the canary in the coal mine. They know before any mental health professional often that the person actually is starting to deteriorate and the symptoms are coming back, but because the professional doesn't see that, they don't necessarily believe them, and we need to really listen to them. Make sure you understand what the strengths and limitations are of the family. If you have people who are living just above the poverty line where, all the family members need to be employed, they cannot stay home, then we need to come up with strategies that will help their loved one in recovery that provides that support that they're not able to do. I also want to say the feelings of loss. Having worked in pretty much every disability area, I know that when your child is diagnosed with a developmental disability at the age of, typically before the age of 5, there is a sense of loss there, but your dreams for your child's future are pretty mushy at that point. But imagine that you have a child in college, maybe they're a senior year in college, they had kind of a career ahead of them. You had a pretty distinct view of what was going to happen to them in their future. And now a serious mental illness occurs. And there is a huge loss there, and no one is providing that support to them. No one's bringing them a hot dish. No one is sending a get well card. No one is saying, everything will be okay. The other thing that we've seen, too, is that improved communication among family members. There might be another child in the family who is struggling with this, or if it's a parent, and they need some help along the way as well. And then again, encouraging them to have a big support network, not just one or two people, because this is a difficult thing to get through. Just a few more words about HIPAA. I always like to say that HIPAA doesn't require you to be stupid. We want to encourage families to be involved. And families feel like they can't win. If they're really trying to push to get information to be able to help their loved one, they're told, well, you're being overprotective. If they back down and they just don't, ask for anything, then they're not engaged. And so we need to find that kind of middle area. And always people can provide information to you. So even if there's no signed privacy release, even if the person says, no, I don't want my family involved in the discharge planning meeting, you can still listen to them, which will still give you a better perspective about the whole individual. In Minnesota, we actually have a thing called the Family Involvement Law, which actually allows kind of a lesser, most families don't want access to the full medical records. They just want to know what's the diagnosis, what's the treatment plan, what can I do to help. And we pass that as a way to, not get around HIPAA, but provide an alternative to the full-blown medical records. HIPAA does allow professional judgment. You know, if the person is really psychotic and really doesn't know what's going on, they're probably not in a position where they can get consent. And so you can still provide information to the family. And again, make sure that you're involving the family at the beginning in terms of the evaluation and also at the end in terms of discharge planning to make sure that you have a plan that could actually work and that is developed, you know, with the knowledge that families have about their loved ones. We also suggest as part of the RARE report is that you don't just ask once. What we found is that it was only when someone was admitted to the hospital that someone was asked to sign the privacy release, which is probably not the best time to do that. So not in terms of badgering the person, but asking more than once, asking if there's certain information that you can share. And, you know, one of the things that, you know, some people have done is to tell families, well, if your loved one was diagnosed with schizophrenia, here's the different types of medications that could be provided. Here's generally what treatment plans would include, so they can get some general information about what to expect, even if it's not the, you know, full-blown privacy release. For patient engagement, a big thing is really identifying their support network. And, you know, like I say, people can choose their family, certainly, but we want to make sure that they have someone else to lean on, someone else to provide that support in the community. We really need to make sure that they're taught about their illness. We did some focus groups last summer, and it was with people with mental illnesses, and many of them asked, I was told I have schizoaffective disorder. Do you know what that means? Many of them had no idea. So even if maybe they've had this illness for a while, don't assume that they have all the information about it. The treatment plan is really important. It can't just be something that's pretty much the same for everyone. You really need to work with them on it in terms of developing it, but also making sure they really understand the components and why it's important. And then lastly, involving them in changes in the medication. I can't tell you the number of times I've had people who were, you know, very, you know, that had major positions in the community. I had a woman that ran a large nonprofit who was hospitalized for her bipolar disorder, which happened, you know, every couple of years, no matter what she did. And she was in the hospital, and she went to get her medications, and she looked at them, and she said, these aren't the medications that I have been taking. And they said, well, no, we changed them. And she said, did you want to talk to me about why you changed them? You didn't ask me what medications I've been on in the past. And so she was very upset that they changed her medications without consulting her, and she didn't want to take them until she had a discussion with a psychiatrist. And then they threatened her with commitment. And so that's not patient engagement. People really do know often what medications worked and didn't work in the past. We also need to make sure they understand the side effects so they can choose which side effects maybe are easier for them than others. But that engagement piece is, if someone's not engaged in the discussion about what medications to take, the likelihood of them continuing to take them is very low. So, again, partnering in decision-making, reflecting on the pros and cons, also asking if they have enough information in order to make decisions, and are there others that they want involved in the decision-making. If they're feeling, you know, sometimes, you know, especially with depressive symptoms, they may not be challenging anything or asking the questions, so they actually might want a family member in the room who can help them. And lastly, it's just important that everyone's on the same page. You know, the individual with mental illness, their family members, the mental health professionals, that everyone's like, yep, this is going to be the treatment plan that's going to work to go forward. This is going to help on your recovery. Everyone agrees. And then I think, you know, then you see that the treatment plan is actually followed, and you see that readmissions actually go down because someone is really working on their recovery because they agree with the plan. One last point is that family is how someone defines it. So it might not be a traditional family. It might be a very close friend that has been there and they're kind of advocate for a long time and supportive on their journey. And so part of it is also asking, you know, who is it that you want to be considered family in this situation so that they, again, can be involved and help you in your treatment plan. And with that, I am going to move it back to Kay.
Thank you. And some of the things that you've talked about, I think I will re-emphasize. First, I'm going to talk about medication management as one of the factors that relates to readmissions. There are two aspects aspects of medication management. The first is the logistics. Sue already talked about the issue of changing persons' medications. I know that there are sometimes issues between what the formulary is in the hospital and the formulary of the person's insurance. And it's very important to verify their insurance before any new medication is started, besides the issue of talking to the patient. And then obtaining and verifying any prior authorization so that there's not a lag at the time of discharge while they wait for prior authorization, while they wait for their medications. Ideally, filling the prescriptions at the time of discharge so the person walks out with them. This is an issue that's not just for people with mental health. It actually is an issue with people who also are admitted for medical or physical health conditions. That gap between them getting home and the pharmacy is critical. Checking the Medicaid status is especially important depending on their insurance status and in helping them to enroll if they're eligible or it's needed. A third logistic factor with the medication, and some of this is repeat because most of us, it's part of all the readmission material in terms of what are some of the issues and factors, providing full written information, the reason, the dose. And another critical piece is the rationale. And again, that should be something that's discussed with the person and in agreement with the person so that, or their family member or whoever is helping them, so that it is understood and that the written materials provided, both for the providers the person's going home to or the mental health people, but also for the patient and the family. And they all should be consistent. And, some of the things I'm going to say seem like they're so obvious they should be a given, and we would like them always to be a given, but the reality is they're not always a given. So consistency between all the material of what the person's on for medications, what was stopped, what was started, what's to be started when they go home is really important. And then the second aspect of medication you already alluded to is the client-related issues. First is the whole issue of changing meds. Nothing annoys the people in my support groups that I work with than having all their meds changed for a reason they don't know, and to meds they don't know or they already failed on. There are also some other factors that are related to the acceptance and a willingness to take medications. One of them that we don't talk about too much, but I think is especially critical, especially in young people in first time, it's important to the individual and it's important to the family, is the fact that limited insight into their condition and the need for medication is, for many, a component of the condition. 50% of people with schizophrenia have anosognosia, and 40% of those with bipolar disorder. So it's not that the person is necessarily denying what's going on. It's that it's part of the condition. And many have a tendency to blame the patient for not having insight or not being willing to see. A second aspect of medication and willingness is negative attitudes that people can have about medication because of past experiences. It could be because of the side effects, tardive dyskinesia, weight gain, sleepiness, or they didn't help. And there's a frustration of why should I bother taking this with side effects? And just another one that's not going to help me, I'm done, is the common attitude. And, it's tough to argue when you have a lot of side effects and it's not working. I think some of the genomic testing can be helpful in addressing and helping to identify a drug that might be more successful for an individual. And of course, the cognitive challenges of being confused or it being in an acute state of psychosis is not necessarily the best time for some of the education, and that has to be taken into consideration in the timing of the decisions in education. But the bottom line is that even if there are negative attitudes and limited insight, they are factors that are part of the condition, and they need to be addressed as that and not just dismissed. So that's where we start talking about using motivational interviewing or teach back or LEAP, listen, empathy, agree, and partner. Find out what it is that the person is motivated by. Find a way to have a common goal and then address it. And that's also part of involving the individual in their decisions. And it's very important in all this education process that teach back cannot be understated. I've worked with one individual who just barely cannot function with her treatment team because of language and not understanding. Because she does have delusions, and she is challenged by paranoia. And her team tells her, when she describes her situation, her team tell her, well, you're paranoid, just take your meds. She thinks they're telling them that they're using the colloquial meaning of the word paranoid, and they're dismissing her. And that they're dismissing what she's experiencing as not important and not real. She's just being paranoid, and they're brushing her off. So she's not willing to take her meds because they haven't come to this place of teach back and understanding. Another aspect is you're going to be, besides treating the person in the hospital, is comprehensive transition planning, which actually starts at the time of admission in terms of assessing readmission risk factors. This is where some of the things Sue was talking about engaging the family or friends or people who know the individual. They can talk about what are some of the patterns or the triggers of hospitalization or other problems. And it's part of the work of the whole team as well. And the teach-back method is also an important part of the planning and working with the individuals. And then I think the specifics of the care plan is that it's easy to understand and in plain language, very important. Part of the process of the purpose, basically, of our planning is to help a person be able to self-manage. So when we're looking at what should be in a treatment plan, in a transition plan, we have to look at, what knowledge do they need, what resources do they have or need, and what's their level of self-efficacy, what skills and coping do they need to feel confident that they can achieve what the goals are. Sue talked about the fact that the planning needs to be developed with the individual and the family, not for them. The purpose is to identify the goals and the values and what's important to the individual and then work from there. Obviously, all plans have to include a few key elements like medication, which should be clear, crisis management or anticipatory guidance developed with the individual about, what are the potential specific things that might come up. How do they handle them? What are the red flags? Who are they supposed to contact? This should be, talked about and agreed upon and then part of the plan. And then coordinating and planning for the appointments and the barriers that the individual is going to have when they go home. One of the things I think we want to introduce that is not so strongly identified in the different documents that you can see at the end is the focus on recovery. And I think that's one area that's extremely important and a challenge because it requires a shift in how we relate and think about things. The 4 dimensions of recovery identified by SAMHSA, and SAMHSA has some excellent resources on the whole issue of recovery and shared decision-making. But the 4 dimensions are health, home, stable place to live, a purpose, a sense of meaningful activities, income, and resources so they can participate in society, and finally a community, the sense of belonging and having a sense of place. One of the challenges I think about recovery from the acute hospital is not being able to see how the acute hospital focuses or is part of this recovery process. And it's been described that there are stages of recovery, and the first one is remediation, which is basically reinstating the sense of hope and possibility that Sue talked about. For the individual who's so acutely involved and dysfunctional, there's this sense of loss of hope, that there's nowhere to go. They will never, ever be anything more than what they are now in the hospital. And it's a very important part of the recovery that they get the sense that there is hope. I think it's a challenge for staff in hospitals, in psych hospitals, because most of the time you are seeing people at their lowest point. And when they've done different studies on that, that becomes a part of low morale and also a sense of stigma, because it's like, why are we bothering? It doesn't work. There is no future. So it can also take on this sense of hopelessness. And one of the ways that some places have dealt with that is by having people come back 6 months later to show that there was recovery. There is something. There is a future. It did make a difference what happened in the hospital. So those are some of the recovery There's lots more to talk about recovery, but we don't have, it's not our focus today, but we do want to build on the strengths and focus on the future. And I think Sue talked about the fact that discharge plans need to be realistic and understandable. They have to address the individual's goals and not the team's goals. I mean, there should be a blend. It's not just about symptom control and medication compliance. It's also what do they need in terms of transportation, in-home services, obtaining prescriptions, and then again, working with the teach-back method. Care transition support. This also depends on what you have in your communities, where the individual is going to be discharged, whether you're an integrated system. People need to be prepared for leaving the hospital, especially if this is their first time or a different time than they've had the last time. And some recommend that their follow-up appointment should be within 7 days. Ideally, you want to facilitate your connection and have the receiving provider able to accommodate this 7-day appointment. And that's not necessarily always possible, especially as we have growing limitation of resources in our communities. I think a point that can be worked on is at least having a scheduled appointment before the individual leaves the hospital, even if it's not within that 7 days, to at least get something scheduled and something to work for. Another part of the transition is community resources and support. Sue's talked about the importance of this. I should have added it should be both client and family psychoeducation classes. There is a lot of research, and I think the ARC report talks about the research and the support and the value of the psychoeducation classes as well as support groups in reducing readmissions because it works towards self-management skills, and that multiple family groups and classes are more effective than single family because of the sense of connection and also of shared problem solving. Written resources, like Sue said, people need information and they look to their professionals for the guidance. And then advocates. Peer specialist support is also another community resource. If you don't have it, it'd be good to get it. They're valuable both in the hospital and then following out of the hospital for long periods of time, depending. I know care transition is a big challenge. Some have case managers, either internally or in the outpatient clinic, or they work together, especially in your integrated systems. Having a coach that can help with the individual and their family learn the skills and the contents they need. This is a short-term intervention, as described by Dr. Coleman. Many are much more familiar with the Assertive Community Treatment Intervention, or ACT. It's also called PAC, and in Wisconsin I think we call them CSP. Then there are also active short-term case management that's been used. And I know from talking to some of the hospitals that some of you have become creative in how you have created your own short-term case management to bridge the time between discharge and the next appointment that the individual can get. There's an official critical time intervention, which is a specific model. And then also there's collaborative care, where we have integrated mental health and primary care. And then long-term, again, peer specialists. There have been some studies that show that the skill building and hope in association with peer specialists is even up to a year can impact readmission. And then transition communication. Communication is basically the crux of a lot of these things, both between patients, families, team, as well as the discharge. It's a whole system of care, or we would like it to be a whole system of care, which includes starting on admission, notifying each other of admissions, talking about triggers, what the past experience has been. As Sue said, the family and caregivers need to know who's responsible for care. They need to have copies of all the materials so they can work with them. Some have had videos that patients and family can use that would address both transitions, hospitalization, and preparation. warm handoffs. It would be nice to say that people would have face-to-face meetings and treatment teams, and it would be all outpatient providers, clients, and families, and inpatient team. And that would be ideal, and as close as you can come to the ideal, bringing people together is extremely valuable. The reality in discharging between inpatient and outpatient is that oftentimes the discharge summary is the total of a handoff. And that makes it more important that the discharge summary include not just be accurate, include the medications and why things were changed and why decisions were made and what were the patient's preferences and goals and what's the follow-up and what are the outstanding social issues and what are the readmission risk factors, who's going to be following up, what's the follow-up time. Follow-up appointments, having called, one of the factors in readmissions is actually in the clinic or where person is going for outpatient appointments, that they actually are on time, that they're not sitting and waiting for long periods of time for their outpatient appointment. That impacts the rates of readmission. Again, follow-up appointment addressing the strategies for crisis management, for relapse prevention planning, how to use urgent care, when to call, what to expect when they call, when they should use an ER, or whether there's a crisis center, and whether, like in Pontiac, Michigan, there's a crisis center that's the place where people should go. And then providers, again, it would be ideal if the providers on post-discharge could talk to each other, but I realize that probably doesn't happen too often. A transition could also include the use of high-intensity outpatient services. I know there's a number who have these services or are creating them as a way of addressing readmissions. There's also, like I said, the crisis centers, which can avoid readmissions or admission, and also a wise use of peer-run respite centers can be a resource. And then the follow-up phone calls to remind people, as this says, that follow-up phone call should not just be a med check or a light call. It should be a real call that addresses the needs of the individual and how things are going and what the barriers there are and real problem solving. And again, sharing information between providers could be extremely valuable if it's possible. And those are the basic points. The client and family engagement, medication management, comprehensive planning with the recovery approach and collaboration, handoff communication, discharge summary, expedited within 4 days, and then follow-up appointments, community resources for peers and family education and support. And remember, we're talking about people, and you may be seeing them at the lowest point of their life right now, but they are coming back to the community, and recovery is possible. There's no silver bullet, but we can build on what interventions will work for each of you. Thank you. I'm going to open for questions. If you want to add in the chat box, we'd be interested in knowing things that you might have learned already in your process of analyzing your readmissions, what you've created, and also what some of your challenges are. And we will be able to print those and share them with the rest of you. So we can share it, because I'm sure we won't get enough time to talk to everybody. So thank you, and I'd like to open it for questions now.
Thank you.
Back to you, Ross.
Okay. Thank you so much, Dr. Jewell and Sue. That was very informative, and there was a lot of content to go over. So we do have maybe a time for 1 or 2 questions. Jenny, if you're able to open up the chat line.
Thank you. We will now begin the question and answer session. If you have a question, please press star then 1 on your touch-tone phone.
And I guess I did have this question is just one that I had for Kay. For those more rural areas where there is a limited access of mental health providers and services, what are some options that patients in those more isolated areas have to maybe supplement their level of care?
From talking to different hospitals, what some have done is have created their own, like a bridge support group or way for individuals to be connected back to the hospital team or whoever employs them, so that they have a connection while they're waiting for services to begin in their own community. Another option is in some of the areas there actually are resources like NAMI support groups or classes or NAMI activity, and there's unfortunately sometimes a disconnect between the NAMI CHAP affiliates and the hospital in terms of what's needed and how they can work together. So that's another potential resource. And in some places, I think looking at what organizations are there and which ones of them would be willing to develop some new things that would be supportive.
Okay, thank you. So it's more, is this kind of information, is this available like to the public, or is this something that someone would have to like seek out at like the county level, or?
It can be at the county level. I think it depends on the individual and what their mental health need, because in a lot of counties they have like the CFP or the ACT resources, but sometimes there are also other community agencies that provide services, different types of services that may be of value. I know there's like 10 counties that we have an independent living center, and they provide like drop-in centers and different kinds of activities and support and peer specialists. And they're not in the county system, and then there are other agencies like that could potentially be available or could be developed. I think for some, it's a matter of we have to start developing more resources.
Okay, well, thank you very much, Kay. And Jenny, do we have any questions in the queue?
We have no questions at this time.
Okay, and I think we only have about 3 minutes left, so I think it's okay if Jennifer from WebEx, if we just wanted to open up today's evaluation. Hello, Jennifer. Well, I guess Jennifer from WebEx, are you on the line?
I'm here. It's a drop-off, so when everybody closes out, it'll pop up.
Okay, thank you. Okay, thank you so much. And yes, so if everyone could complete that evaluation after the presentation, we would greatly appreciate that. We use a lot of the feedback and insight that you guys provide to make future webinars and presentations more valuable for the attendees. And I also did want to mention that we did have, here at Minnesota, we are offering an expert training, and very briefly what that is a screening, brief intervention, and referral to treatment for behavioral health patients, and it provides valuable basic education for alcohol and substance use issues, a model for behavioral health integration with primary care practice, and also a education for useful communication skills for interacting with patients. So this is kind of just some more education and tools for improving the quality of care that you have with your behavioral health patients. And I will put that link in the chat box as well. And for that, you would contact Mary Funseth here at Metastar.
There are two resources, this is Kay. There are two resources I forgot to mention that have been really helpful. SAMHSA, as I said, has some great resources. One of the sections is Recovery to Practice, and they had a webinar last week on integrating and addressing first-time psychosis in the clinical practice. It was extremely interesting and valuable in terms of what the shifts are, what's the difference in thinking and recovery, how do you address that? And so it was just very enlightening. And then there was another one yesterday. There's a series also by SAMHSA, and yesterday's was on trauma-informed and crisis management, and it was basically the crisis center in Pontiac, Michigan, talking about what the center is. Their maximum stay is 24 hours, how they work with individuals, how they've redesigned how they work with individuals to basically have a hands-off a policy as much as possible for aggressive intervention. It's an extremely valuable and interesting webinar, and that one is going to be available. Both of them will be available in about 10 days, and the crisis one is available at NASMHPD.org under their publications.
And
there's a series, that will be a series that's going to be out.
And this is Sue. We have a lot of written publications on the NAMI Minnesota website, including how to develop a crisis plan, what are the data practices, policies, things like that.
Okay, great. Thank you so much, Kay and Sue. And you guys, you two would be available if anyone that was attending today's webinar had any questions or just wanted to talk. They could feel free to reach out to you.
Yeah,
absolutely.
Great. Thank you so much, guys. And thank you so much for, once again, for presenting today. It was very informative. And this concludes today's educational session. Remember that the PowerPoint presentation is a WebEx handout, and the links also to that PowerPoint presentation are also in the chat box. And the recording will be available in about a week or so. There's a link also to that, to our YouTube page, and the recorded presentation will be available on that YouTube page. And once again, please take a moment to complete the evaluation and provide your feedback to help us continue to make these quality events. Thank you for spending your time with us today, and have a great afternoon.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now